Hello. Okay, welcome back. Oops, I always forget to erase stuff that we covered on the previous one, but that's okay. Then you know where we're going. So we're still on pulmonary. It's the last of the four case studies that we're doing right now. So we already got the concepts down of the obstructives. We're not doing any case studies on restrictives, but you guys understand what that concept is too. I do have extra videos that I'm going to expect you guys to watch. I will do my best to provide a link at the end of the videos for these case studies so that you guys know the direction to go. They're also provided at the bottom of each of the modules. So any which way that I can direct you to watch those, I will. We're going to do pulmonary embolism on this case study. So you guys understand. Oh man, I did the video after this to cover this topic. Darn. Okay, we're just going to do it again. I assume that I didn't teach you this. Pulmonary embolism. Right? Pulmonary thromboembolism. What is a thrombus? You're going to hear me say this again later, but that's okay. It's good reinforcement. When I do cardiovascular and MI, it talks about it. So, it's a little shitty to get a thrombus. Thrombus is a clot, right? So a clot formation, this clot can go anywhere. Once the clot is formed, it can end up as an MI, could end up as a PE, could end up as a stroke, right? An ischemic stroke, hopefully not hemorrhagic, but we'll get to that later. So here we go. 3 factors. This is called Virchow's triad for thrombus or clot formation. 3 factors that contribute to the formation of a clot are stasis, injury, hypercoagulability. Hypercoagulability. Hypercoag means the red blood cells are more sticky, right? So they're more likely to clump together and form a clot. Injury and stasis, best example is going on a 13-hour flight to London from Hawaii. Usually you have to like transfer to New York or something, right? But the whole point is you're sitting for a long period of time, your knees are bent, right? So this could be like a physical injury, an actual injury that causes the clot to form, or a theoretical injury, right? With your knees bent, there's injury sites at which the blood vessel themselves are kind of like, instead of straight, I can't make my hands straight, sorry. Instead of straight, it's like bent. So that's a point of stasis. That's also a possible point of injury. Um, Hypercoagulability, 3 factors that can contribute. If you're female, you have high amounts of estrogen. That makes the red blood cells more sticky, right? Female also as, I am taking birth control pills, right? Birth control pills, or I am a cigarette smoker. Anything that contributes to causing the red blood cells to become more sticky. Stasis. What conditions can you consider stasis? AFib. AFib is a good one. So if I have AFib, right? And I want to get them into a normal sinus rhythm, what do I have to do for them? Well, I have to probably cardiovert them, right? But I can't cardiovert them until I determine that there are no clots inside of the atria that could be passed through the lungs and potentially cause an MI or even a stroke. So in order to make sure that I don't, I would do like a TE, right? A transesophageal echo. If I don't see any clots, then maybe I can cardiovert them and return them to some kind of sinus rhythm. You can do this several times, but you have to make sure that you don't have any clots present. Let's say that I missed the clot, right? And that clot in the AFib, right, in the atria, that clot is now shunted from the atria, let's say the right atrium, to the right ventricle and is pushed up into the lungs. That's one source of a PE. What are some other sources? Well, you could be a fatty embolus, right? It could be what is the difference between a thrombus and an embolus? Only difference is the thrombus is a plaque that builds up at one site. The embolus is that plaque or clot breaking off that site and traveling to somewhere else. So this could be a clot from like AFib. It could be a clot from Maybe they have a DVT, right? They have a DVT, a deep vein thrombus. Um, or they have a broken leg, right? So post-surgery or post-surgical intervention when somebody that's doing like a TK, total knee replacement, or even a hip replacement, you worry about the fat from within the bone actually traveling up to cause the pulmonary embolus. So let's go over just case study really quickly. Severe chest pain. I can't seem to catch my breath. I think I may be having a heart attack. Similar symptoms, right? Mrs. VA, 30-year-old woman, presents to ER with 90 minutes of chest pain. So again, as with the MI that I do a little bit later, I should have done this one first. Um, clots, stroke, clots. What do we have to think about? Someone with stroke, you think fast, right? Clots. It takes like 4 hours before the clot to solidify to the point that medical intervention, right? Medicine intervention doesn't work. So you have up to maybe about 4 hours of leeway to give what we call TPA. TPA is also known as streptokinase. That was the original streptokinase. It's an enzyme that breaks up the clot, right? It's a clot buster. In this one, I think the brand name is Altiplace. I'm more accustomed to doing generic drug names. Sometimes I go back and forth to the brand. So here we go. 90 minutes, chest pain, describes severity of pain, 8 out of 10. Hour half ago, she developed sharp, constant right-sided chest pain, right-sided mid-back pain. Pain became worse when she attempted to lie down or take a deep breath, and improved a little when she sat down. Oops. Oops. Pause. Okay, so let's do that again. Sorry about that. Pain became worse, attempted to lie down, take deep breath, and improved a little when she sat down, so upright. She also had difficulty breathing, denies any fever, chills, coughing up blood, reports that she just returned home 36 hours ago, following a 13-hour flight from Tokyo. Good thing we already talked about that, right? So we're looking at the pathophys behind the clot formation itself, right? Leading to the clot. So 13 hours of stasis, that leads to clot formation, right? That's why, what do you tell your patients? Or, you know what? Let's put this into your perspective. What do you tell your family member to do when they're on long flights? Get up, exercise, walk around, hydrate, hydrate, hydrate. The more viscous the patient is, the more dehydrated they are, the more likely they are to have hypercoagulability, right? The blood vessels are next to each other, they're kind of like bumping, so they're bound to form clots quicker. You're bound to get more DVTs than someone who is up, around, and hydrated well. So, migraines since age 23, mild endometriosis, positive protein S deficiency. I believe that might be a factor, but let's skip that for now. One episode of DVT, 2 years, so you know she has a history of it, right? So hopefully on her medication list, she's going to have prophylaxis of some sort in her profile. Um, Treated with warfarin, okay, for 1 year. That means she's not on prophylaxis. Hopefully she's on some kind of aspirin. Acute sinusitis 1 year ago. Past surgical history, orthopedic surgery, leg trauma, age 7. Probably not contributing to current state. Ovarian cyst removed 10 months ago. That's a possibility. It is a while ago, but the injury itself could have caused clot formation. Kind of far. Family history, hypertension, mom and dad, mom, metastatic cervical cancer, brother alive well, no family history of DVTs or venous thromboembolic disease. Social, lives with husband, monogamous relationship with 10 years, sexually active. So the question you have to ask is, she's probably on an IUD, and that is, like what we said, it is birth control, right? The birth control is contributing to hypercoag, so she's at risk. Hopefully she's not a smoker. She has a history of DVT. That's also another risk factor that's contributing to her current state. She was on a 13-hour flight to Tokyo. It's not that long from Hawaii. It's only like 7, if I remember. Was it 7 or 9? And then stasis, she's sitting for a long period of time. She has a lot of things that are contributing to this formation of clot and therefore this pulmonary embolism. Um, Patient patient lived 12 pack years. Oh my goodness. This case study has everything that can contribute to this patient. This is the pathophys behind it. What are the contributing factors and what is the cause of this? So we're trying not to focus on the assessment. The assessment, that's your job. That's what you guys do in the clinic. We're looking at the compounding variables behind it, the contributing factors, the pathophys, the development, and this is what I'm testing on, not so much the assessment, even though the assessment is a bonus for you guys. Business executive, so she's probably stressed a little bit, maybe some vasospasms. Negative for alcohol or IV drug use, occasional caffeine intake. Okay, so here we go. Here's the contributing factor. This is your birth control pill. Amitriptyline, maybe she's depressed or she has fibromyalgia, but this one is at night, right? They could just be using it to help her sleep. Heifer got migraine, okay, every 30 minutes. Metoclopramide, what was her? Endometriosis, DVT. Okay, ibuprofen, right, for her cramps. Blood thinner, but you notice I don't know why she's not on this. What would you guys put her on? What is she supposed to be on? She has a history of DVT. What are people with a history of MI? I know you're probably screaming at me. You're like, aspirin! Yeah, I don't know why she's not on like 81 milligram low dose aspirin daily to prevent clot formations, right? She has a history. You don't want her to get an MI. You don't want her to get a PE. You don't want her to get a stroke. Put her on prophylaxis or STDs. Just joking. Okay. Review of systems. Let's go through anything that we can. Makes me goofy. Sulfa allergies. Well developed, so you guys can go through that. Normotensive. Ooh, well, we already can figure out this is contributing not contributing factor. This is the result of having, okay, let's do the pathophys behind it. How do you diagnose this? Right, some of the physical, but then you also do a VQ scan, right? What is a VQ scan? This is the lung. This is the, these are the blood vessels. This is a very general diagram. It doesn't really look like that in my body. But this is the alveoli. If I have an obstruction here, we did those. Those were called, could be called a peanut, right? A child inhales a peanut right there. And it's, V is ventilation. And I put a dot because it's usually like an amount per minute, so mLs per minute. And Q is what we call perfusion. It's the ability of blood to transport toward the alveoli. So aeration or ventilation and blood flow match so that the oxygen brought in through breathing can be transported into the blood for use with any of the tissues that need it, right? So this is VQ match, great ratio because I'm breathing in oxygen and I'm able to take it to the tissues. What is a VQ mismatch? Well, I could have a low ventilation, right, and a normal perfusion, and my VQ would be low. That's because maybe the obstruction is a peanut and I'm not getting oxygen in, so therefore my O2 sats are going to be low, right? So I have to remove the obstruction. Right now we're talking about this guy having a pulmonary embolus, obstructing the flow of blood. That means that I'm not able to transport the oxygen that might be coming in. So my ventilation might be high, but my perfusion is low. So in this case, even though it sounds like it's still decent, no, it's the ventilation is high and the perfusion is low, so your VQ ratio would be high, but it doesn't mean that you're getting oxygen in. It just means that you have lack of blood flow to carry the oxygen. That's because you have a clot. This is called a PE. So maybe I do a VQ scan. Let's look at this. Fair complexion, we can look through that. Neck supple, no bruise. Cardiovascular, rapid but regular rate. So she doesn't have any kind of arrhythmias, no murmurs, no gallops or rubs. Tenderness, no wheezes. So you know that it's not a pulmonary dysfunction. It's a cardiovascular dysfunction. So we get to here, we can move on. Positive bowel sounds, no hepatosplenomegaly. Normal, no lumps, mass. Okay, let's get through the stuff that we want to go through. No cyanosis clubbing, so you know this is not not long term. This is all of a sudden 36 hours after a 13-hour flight. So let's look at her lab values. Okay, these are going to be normal. BUN creatinine are going to be normal. Hemoglobin, maybe she's slightly anemic. She could have iron deficiency, right? Because she's a female. She's within the age that we're going to still have menses, menstrual cycle. She doesn't have infection. Platelet count is there. So what are we looking for in this? The values aren't going to show us. Echo, sinus tachy. I'm sorry, EKG, sinus tachy, echo, ventricular wall movements within normal. So what does that tell you? That tells me that this clot didn't get to the heart. So I'm not having an MI. So if it was an MI, you might be looking at troponin I times 3. You might be looking, if you considered that it was congestive heart failure, you saw JVD, saw hepatosplenomegaly, you saw leg swelling, then maybe you look at BNP. No, but we're not looking at either one of these. We're trying to rule it out. We're saying that the ventricular walls are moving normally, so there's no abnormality or dysfunction. So it's not necessarily an MI that I'm trying to look for or rule out. I'm ruling out that that's not it. Uh, Lower extremity venous duplex ultrasound. So I'm searching for a DVT, right? I'm searching to see if there's a DVT there. Let's see if they find it. Both right and leg lower extremities, abnormalities in venous narrowing, prominent collateral circulation. So we already know she has a history of DVT. So they're looking to see if there's anything right now that might be moving upward. So yes, findings are consistent with bilateral DVT. Yes, positive. Okay, VQ scan, we just said that. VQ perfusion defect on the right base. So she's having a hard time. Let me pause again. Okay. Okay, sorry about that again. Thank you. So we got perfusion defect right base, some mismatch between perfusion abnormality and ventilation of right lung. You guys are so awesome. You guys already know the answer to this, right? We said there's a VQ mismatch because there's a lack of blood flow because of an obstruction from a clot or a PE, which is causing a deficit. And we said it's in her right lung. So her symptoms are associated with the right side. She's been having right-sided symptoms. How do I treat? Let's see how they're doing it for clinical course, right? Pulmonary angiogram, abrupt arterial cutoff in peripheral vessel in right base. Why? Because there is an obstruction, right? Probability for pulmonary embolus right here in the right peripheral base because there's an obstruction. Here we go. So this is chest x-ray, presented chest pain, hypoxia, lower DVT, right? Woohoo! That was it. That's basically all you guys need.